Hey, good day, everybody. This is Joe Gallo from ASPE. Um, Before we get into the program, I'd just like to give you a couple of administrative reminders as we go along. Uh, we would sincerely ask you to please mute yourself. And if you're not part of the presentation, at least until we get to the Q&A, this is not a medical presentation. So anything that is presented either verbally or written, or on the screen is intended as information, and it's not representing any particular position of ASPE. If you have something that you hear today or that you want to follow up on, we strongly suggest that you go back to your physician or your medical facility to get more advice. So take what you learn, but then move on from there. Throughout the presentations, there's an opportunity for you to be able to put questions into the chat that will be then covered after both presentations are completed, but you can start putting them in at any time, and the various moderators or board members will pick them up, consolidate them, and present them, and we will take it from there. And with that, I'd like to welcome you, and here is Mark Lichty, the chairman of ASPE.
Thank you, Joe, and I welcome all of you. We want you to know that in this journey that you're on, you are not alone. ASPE and other organizations are here to support you. One of our missions at ASPE is to help you to reduce your anxiety. We want you to shift from anxious surveillance to peaceful vigilance. And believe it or not, that's possible. With advances like genetic testing, our worry can be radically reduced. When I was first diagnosed with prostate cancer 17 years ago, I was uncertain for several years as to whether I had aggressive cancer. With the tools that we have today, you no longer have to be in that place. With that, I would like to introduce Jeff, who produced the program, and you're on, Jeff.
Thank you very much, Mark and Joe. Thank you, Myriad Genetics, for making this program possible and supporting ASPE. And following up with what Mark is talking about, I like to think of the word positive and research and working the family team, your family, with your clinician. I mean, there's just so much good happening in our world. When I began active surveillance over 10 years ago, quite frankly, I was scared because I lacked the knowledge that we're going to present, some which we will present to you today. I remember how many times I went into a doctor's office and they said, tell us about your family history of cancer. And I started to think about all of my relatives who some were either unable to remember or were already passed, gone on to the next life. So fortunately, we're working into a new world, the how and the when and the why should I get a genetics test? And that's what we're here today. We've got two exceptional researchers and presenters that will take us through the world of how and when to get a genetic test and what it means to you. And also, as I mentioned earlier, what's critically important is the family. It's not just you, it's where you come from, your parents' genes. And then perhaps one of our speakers, and perhaps Dr. Glode, Michael Glode, is going to tell us the genomic test. It's not just genetics, it's also genomics and the close relationship. Now getting into introducing our speakers. Our first leadoff speaker is going to be Rob Finch, Master of Science, a certified genetic counselor. He's a director of urology and medical affairs at Myriad Genetic Laboratories. He has an extensive career, master's degree in human genetics, University of Pittsburgh. Also worked at Memorial Sloan Kettering Cancer Center in clinical genetic services and studies, colorectal cancer, and joined the Myriad team in 2003. And as I mentioned, he's the Director of Urology Medical Affairs, and he's also a genetic counselor. He will lead off, followed by Dr. Mike Glode. Dr. Mike Glode has over 50 years of practice and research, both in the United States and Europe. We're talking about his career at University of Nebraska in zoology, Washington University School of Medicine, St. Louis, University of Texas Southwestern, his residency, that's the Parkland Hospital, National Institutes of Health at Bethesda, Maryland, where he did research in immunology, Dana-Farber Cancer Institute, Massachusetts, oncology, and gene technology at University of Helsinki. Welcome to both these wonderful experts, and I can't thank them enough for taking their time, being generous to help us, men and their families, understand what is genetics, what is genomics, and how can we live longer. With those positive words and thanks, I would like to begin the program. I would like to remind everybody, please mute yourself. We don't want to hear your favorite Beethoven, although it's pretty. And then I would also like to tell you that we have the chat room. You can begin asking questions. And after both speakers, we will have a question and answer session. So I want you and your family, your children, your aunts and uncles, everybody to get involved here because genetics is a family affair. Thank you all.
Hi, everybody. My name is Rob Finch. I'm a certified genetic counselor, as well as the Director of Urology Medical Affairs with Myriad Genetic Laboratories. I'm here to talk about genetic testing and genomic testing in prostate cancer. So the first thing we should talk about is the difference between germline and somatic genetics. And those terms, genetics and genomics and germline and somatic, are kind of thrown around. So when we're talking about somatic genetics, we're talking about genetics that are specific to the tumor itself. And so if you have prostate cancer, if there's a breast cancer, any type of cancer, the mutations that are in the tumor itself are considered somatic mutations. Most cancer is sporadic, and so these mutations are not inherited, which, you know, germline mutations are inherited. So a germline mutation is a change in the gene that was inherited from either mom or dad, and that's important. Some people think that we only get cancer genes, for instance, prostate cancer genes from dad's side of the family, or breast cancer genes from mom's side of the family, and we get them equally from both mom and dad. These germline mutations cause what we call hereditary cancer. And it's about, you know, this is about 10 to 20% of all cancer is considered hereditary. So looking sort of at the piece of the pie of cancer itself, specifically prostate cancer, again, most is sporadic, meaning it happens by chance. It can be caused by aging. It can be caused by environmental exposures, such as smoking or sun exposure, et cetera. But the majority are just caused by chance. We then have a piece of the pie that is about 25 to 30% that we call familial. And this is when we can see that there are more cancers in the family than we would expect based upon statistics alone, but we can't find a genetic change to explain those cancers. It could be that that genetic alteration hasn't been discovered yet. It could be that it's a shared environmental exposure, but there's nothing that we can quite pinpoint what's causing that familial display of cancer, but we know that there's more cancer than we would expect. The final category, which is what we're going to talk about today, is the hereditary cancer. And this is about 10 to 20% of all cancer. When we're talking about hereditary prostate cancer, it's about 17%, the literature shows. So one of the things that we look at when we're looking for hereditary cancers is we're looking for multiple cancers. So a combination of cancers on the same side of the family. It doesn't have to be just prostate cancer, although some urologists just ask you about a family history of prostate cancer, but really it's important for us to know about all of the cancers on the same side of the family. We're also looking for young ages of diagnosis. So for instance, having a grandmother who had breast cancer at 95 is not all that uncommon, but if your grandmother had breast cancer at 45, that makes it much younger than we would expect in the general population. And so that's of importance when learning about your family history, as well as when discussing your family history with your physician. The last thing that we're looking for is rare cancers. And so ovarian cancer is rare, male breast cancer is rare, pancreatic cancer is rare. Now, prostate cancer is not rare, but metastatic prostate cancer is rare. And so you can see in this individual, in this family, this is 4 generations looking at the family history, and we can see breast cancer in these 3 individuals in that second from the bottom generation. We see a prostate cancer and ovarian cancer in the next generation up, as well as a prostate cancer in that top generation. All of those are important. They may not seem to be related, but they actually are related. So why is knowing this information important, whether or not your cancer is hereditary or not? So for people with cancer, this can really give you an explanation for why you got cancer. You have an alteration that was passed on from either your mom or your dad, and it increased your risk for developing cancer, and so that is why you developed cancer. But it can also help determine treatment. And so for individuals who have, for instance, prostate cancer, and we know that they have a germline mutation, that can help us to decide whether or not we need to do active surveillance versus more active treatment, such as surgery. If that cancer progresses, it can also clue us into what drugs can be used to treat that cancer. Now, for people without cancer, this is still important. So for family members, et cetera. And this, it increases their risk for developing cancer as well. And so there are screening recommendations that start at earlier ages than is often recommended. So for men, for instance, with a germline mutation, they're recommended to start prostate cancer screening at the age of 40 instead of the age of 45. Now, that doesn't seem to be, too much of a difference, but when we're talking about breast cancer, those individuals will start mammograms at the age of 25 instead of at the age of 40. And so depending upon the cancer type, depending upon the gender, and also depending upon the germline mutation, increased screening starts at earlier ages. Some patients may also choose to have preventive surgeries or hormone therapy to substantially reduce the risk of developing certain cancers. And so, for instance, for a woman who has a BRCA1 or 2 mutation, she may opt to have a bilateral mastectomy with reconstruction to lower her risks for developing breast cancer. So let's look at a patient profile. This gentleman is the age of 68. He had a PSA of 7.3 prior to his prostate cancer biopsy. And the biopsy showed a Gleason score of 3 + 4 = 7. He had 17% positive cores. Clinical stage was T1C. He did have a couple of comorbidities, so he had hypertension or high blood pressure, as well as diabetes. So according to the NCCN risk categories, this gentleman would fall into the favorable intermediate category. So this is somebody who we would target for active surveillance. However, if he had a germline test and was found to carry a BRCA2 mutation, then we know that that cancer has a higher likelihood of being more aggressive. And so despite that favorable intermediate category, this is somebody who we would want to talk about having more aggressive types of treatments. So again, for people with cancer, we talked about the explanation for why you got the cancer, but really we're looking at the determination of treatment. And so for this individual who had the BRCA2 mutation, he and his physician might opt to have surgery instead of active surveillance, just knowing that that cancer is more likely to be more aggressive based upon the germline mutation. Down the road, if this individual had a cancer that progressed to metastatic disease, there's a whole new class of drugs called PARP inhibitors that are now targeted to individuals who have these BRCA1, BRCA2, as well as a handful of other gene mutations. And so, again, this can help determine treatment for these individuals. Now, once we know somebody has a germline mutation, this is hereditary, so we do pass everything on, to our sons and daughters. Our brothers and sisters also have 50% of the same genetics because they came from our same parents. And so looking at brothers and sisters, sons and daughters, all are at 50% risk to have that same mutation. So again, for people without cancer, this means that they would need to start increased screening at earlier ages, and also they may decide to have preventive surgeries or hormone therapy. So looking at this particular family, we're going to go through the generations here. So the one in the middle is this individual, the prostate cancer at the age of 52. He was tested. and was found to carry a gene mutation. And so for the urologist, this gives that urologist information about the consideration of a more aggressive prostate cancer treatment, such as surgery. Now we know that individuals with BRCA1 or BRCA2 mutations are also at increased risk for male breast cancer. And so this particular individual would go back to his general practitioner and say, I have an increased risk for male breast cancer. So let's talk about how I can screen myself for those, but also or how you can help me screen for male breast cancer. Some individuals with a BRCA2 mutation also have a higher risk for melanoma. And so this would be an individual that might go to his dermatologist and just say, hey, let's take a deeper look at my skin. Let's just, look at it more regularly. And so that we can, prevent individuals from developing these types of cancers. Now, for his brother, who is unaffected, does not have cancer, he would talk to his urologist about earlier and more frequent prostate cancer screening. Knowing that he has that BRCA2 mutation that his brother had, we know that his risk for prostate cancer is about 20%, which is higher than that of the general population. And so his urologist would want to watch him more closely, maybe start screening earlier and then more frequent. Again, with his general practitioner, he would want to talk to his general practitioner about the increased risk for male breast cancer. And then the dermatologist, again, doing annual skin checks to check for skin cancer. Now, this gentleman's daughter also inherited that BRCA2 mutation. And so she's going to want to go to a breast specialist, and she's going to want to talk about earlier screening, for instance, mammograms and breast MRIs, and she may also decide to have prophylactic double mastectomy with reconstruction in order to reduce those risks. Now, we talk about the risk for a male to develop prostate cancer being about 20%. For a woman who has a BRCA2 mutation, she has up to about a 90% risk to develop breast cancer. And so that's why we talk about a little bit more dramatic surgery, like a prophylactic mastectomy with reconstruction. Now, women who have a BRCA2 mutation also have an increased risk for ovarian cancer. And so she's going to want to go talk to a gynecologic oncologist and consider an oophorectomy after she's done having her children. And then again, with the melanoma, she's going to want to talk to her dermatologist about doing annual skin checks. Now, those are for the individuals in the family that do carry that same mutation. Let's look at somebody who tests negative, because remember, we only have a 50-50 chance of inheriting this if our parent has it. We only have a 50-50 chance of passing it on if we haven't. And so for Jenny and Holly, they're age 32 and 35, we know that they do not carry the BRCA2 mutation that's found in the family. And so they have general population risks. Their risk is not zero, but they want to go ahead and be screened like the general population. So they can wait until 40 or 45 to start having their mammograms. We don't need to worry about gynecologic screening, just general population screening. So how do you get genetic testing? Well, first and foremost, talk to your healthcare provider. They can help you determine if you are an appropriate candidate for genetic testing. Once you're deemed to be an appropriate candidate, you can submit either a saliva sample or a blood sample. Because our genes are in every cell of our body, we can find them in saliva and we can find them in your blood. During COVID, we had to start thinking about at-home options. And so now there are in-office options with your provider. There's also at-home options if you want to be able to do this genetic testing in your own home. You'll be contacted if your insurance doesn't cover it, but I have to say, especially in prostate cancer, about 96% of individuals who are deemed appropriate for genetic testing, which is basically all men with prostate cancer, so about 96% of them are being covered at some level, most of them being covered at 100%. If there is any out of pocket, it's usually around $50, but again, you'll be contacted if your insurance doesn't cover it. But remember, we all get explanation of benefits from our insurance company that shows the amount that was billed to the insurance company, and that is not a bill. That is just what the insurance company is being given in order to pay for that. And so don't be surprised if you get what's called an EOB or an explanation of benefits. The last thing is be patient. These results usually come back to your healthcare provider within about 2 to 3 weeks. And so you'll make an appointment with your urologist in order to be able to discuss these genetic test results and what they mean for you. Now, once you have your results and you discuss with your provider how you're going to use those in your treatment, you want to remember that this is important for your family members. And so talk to your siblings, talk to your children. Anybody in the family is at risk for carrying these same mutations. And so they can go to their healthcare provider and make sure that they have the same options for reducing their risk for cancer. Now at Myriad, we have a lot of financial support. Again, I say most patients don't pay anything. There is broad insurance coverage, but for instance, if you happen to be one of the few people who doesn't have insurance coverage of this type of genetic testing, we can work with you to make sure that this is not something that's cost prohibitive. We want to make sure that you get the information that could potentially save your life. We also have patient support that has billing assistance, customer service. The support group that we have is My Support 360. We also offer financial support. We have the most genetic counselors of any company or any hospital system in the country. And so those genetic counselors are available to answer any of your questions that you might have, or even to provide you with a more formal genetic counseling session, if that's something that you would want to have. And then we've been around for over 35 years. We're not going anywhere anytime soon. And so we do have lifetime clinical support for individuals who are tested through the laboratory. Some final thoughts. I do get a lot of questions about health insurance discrimination. If my health insurance finds out that I have this gene mutation, are they going to drop me? And that's just simply not true. That was something that we considered a possibility back 35 years ago when we started doing this testing. But we do have the HIPAA legislation, which is the Health Information Portability and Accountability Act, as well as the GINA legislation, the Genetic Information Non-Discrimination Act, that prohibits insurance companies from discriminating based upon health insurance. And so it's important to remember that that information is not used for discrimination. Now, life insurance is a little bit different depending upon the state. Life insurance is considered a product, and so life insurance companies technically can discriminate based upon genetic testing information, but that's really mostly in the case of an individual who doesn't have cancer. So they are finding out that they are at high risk for developing cancer, the life insurance can be affected. What I told my patients was, go get your life insurance before you get the genetic testing. Now, for somebody with cancer, they already know that you have cancer. And so that's not, the genetic testing portion of it is not going to affect life insurance at all. And the last thing is, there has been a scam that's come up in the last several years where individuals who are especially in their older years are getting phone calls from laboratories that have just been set up that are not legitimate laboratories, and they're being told that they are recommended to have genetic testing. They're being sent a kit through the mail, and they're being asked to spit in a tube or go get a blood draw. And nobody will ever reach out to you proactively and tell you that you are eligible for genetic testing. This is something that you should decide with your healthcare provider. Those laboratories are testing, and they're also charging Medicare specifically. And Medicare has now come out with a statement suggesting that this is a scam and alerting, especially individuals of older age. So with that, I thank you for listening to me. I thank you for being, or I thank everyone for inviting me to talk, and I'll open it up to any questions if there are any.
Hello, I'm Dr. Michael Glode from the University of Colorado Cancer Center, and I'm going to talk to you about some of the somatic tests, genomic tests for prostate cancer, and primarily focus on low-risk disease, which I think is the most relevant to this group of men interested in active surveillance. So I hope to cover how the tests were developed, which tests one might order, and then in the end, interpreting the results. So before we get into that, I just want to review that germline mutations could be tested for by anything like 23andMe, for example, where either blood or saliva, for example, could be tested for mutations in cancer genes. These are present in the egg or sperm, they're inherited, and they can cause cancer family syndromes. So most of what I'm going to talk about is not relevant to that. We will talk a little bit about a gene called BRCA2, which is a high-risk gene in prostate cancer. But for the most part, what we're talking about here are non-germline tissues. That is, that a tumor has developed mutations in various genes relevant to keeping that tumor going, and they're present in the tumor only. So breast cancer, colon cancer, lung cancer, all of those have mutations which increasingly can be analyzed and utilized to determine what kind of treatment might be best for a given patient. So the genomic classifiers for treating prostate cancer in the newly diagnosed setting, Dr. Crawford has talked about screening population and using initially the PSA screening and a digital rectal exam, which has been around for 30 or 40 years. And then when patients have an elevated PSA or suspicious digital rectal exam, going on to other tests, in the case of this being found in a primary care office, it might be the indication to go ahead and refer to a urologist who might be more familiar with carrying out some of these tests and their interpretation and what to do next. These days, for the most part, patients get an MRI of their prostate, and that helps the urologist determine which part of the prostate to biopsy, etc. And sometimes the MRI machine results can be fused with the ultrasound that is being used for the biopsy, and that has really changed things considerably in the last 5 years or so with regards to diagnosis and picking up cancers more easily. After that, we would get into the possible use of a molecular marker, a classifier. There are 3 of them we'll talk about: Decipher, Prolaris, and Oncotype DX. Those tests can further amplify some of the differences between patients who have low-risk disease and classify them into low risk, very low risk, etc., that could be best managed by active surveillance, as a number of the men on this seminar are. And then some of these patients who would have what looks like low-risk disease by clinical criteria might have a high-risk genomic classifier and choose to go ahead with definitive treatment using a radical prostatectomy or radiation therapy. So before we go on, let's just look at where we've been in the past. I think most people in this seminar would be familiar with the Gleason scoring system. Tumors that look very well differentiated, very hardly different at all from normal tissue, are classified as Gleason's 1, 2, or 3, and for the most part, Gleason 3. The pathologists rarely use Gleason 1 or 2 scoring anymore. And these tumors are very well behaved, but if you have any pattern 4, that's a red flag for an indication that the tumor might be more aggressive, and clearly pattern 5, where the cancers stop forming glands and they're just sheets of cells, as shown there, would be an indication for treatment in every case. So this has been categorized further and into a Gleason grade grouping system, and I'll talk about in the next slide. This is a picture of another clinical piece of information, the MRI of a prostate, and there's a system called PIRADS that can classify a lesion that's seen into a high risk or low risk as well. There are 2 interesting things about this. Under the microscope, everything that leads to these different classifications ultimately results from genes. So genes are carried in the DNA and then expressed in RNA, and depending on how much RNA is expressed from a DNA template in a tumor, we'll say, some tumors might have a whole lot of a cancer-causing protein encoded by an RNA, and the amount of RNA in a tumor sample can be now quantitated And that's what's led to these genotype marking systems. But in the long run, the pathologist already has a darn good idea without knowing any of this by looking in this system here, which has been around for close to 50 years and has stood the test of time. All of these different gene changes play out in something you can see under the microscope. So one of the challenges has been how much more information is hidden that you can't really see in the microscope if you were to look at individual proteins or the RNA that encodes those proteins. And that's what led to the genomic classification. So the clinical classification of prostate cancer is now not just Gleason 3+C, 6. We call them grade group 1, 2, 3, and 4, etc., where patients with more pattern 4 than pattern 3 in a biopsy actually have a worse prognosis. And then the higher risk patients are almost never referred for active surveillance, of course. So the NCCN risk groups, this is the National Clinical Cancer Center Network, that is for the very low and low risk groups, include patients who are found by an elevated PSA, and they have grade group 1, usually Gleason 3+3, a low PSA less than 10, and fewer than 3 biopsies that are positive in a 12-core biopsy system. And you can also look at the size of the prostate and how much PSA there is in the bloodstream and do a PSA density test. So those are really low-risk patients that we think should generally be followed by active surveillance, and that also extends to patients with just low-risk disease that might have a palpable lesion and not a normal prostate exam, but have some of these other characteristics. The higher risk groups, which we don't need to go into, are patients with favorable intermediate, and these patients might have localized disease but be in grade group 2 and have a low or intermediate level of PSA. They might be considered for active surveillance, but rarely is that the case. And then there are the higher risk groups. This scoring system, grade grouping, has been validated now for some time, as shown on the next slide, by the Hopkins group. These are the very low risk patients in terms of their probability of recurrence, free progression. So patients with a grade group 1 through Gleason 3+3 really at 10 years have only a 10%, 5 or 10% chance of any progressive disease. And that's in contrast to the patients with any pattern 5 that end up down here in grade group 5 who have a very high chance of progressing even if they have treatment. So again, this question that we're going to explore today is whether adding genomic markers to that could improve on what we just looked at in terms of predicting outcomes. So actually, Dr. Crawford, who's already spoken, has done a great job of following these markers and making them easier for those of us who are clinicians to understand. And if you want to read in more detail about the prostate markers and how they work and how they were developed and so forth, I strongly recommend going to prostatemarkers.org. And if you click on the Who to Treat session here, you'll find that the Who to Treat comes out with several tests, and they're more in development. But today we're going to focus on the 3 that have been around the longest: Prolaris, Oncotype DX, and the Decipher prostate score. So what is it that these tests actually measure? On this slide, I sort of show that they've picked, the companies that have developed these tests have picked different kinds of genes to look at. In the case of Prolaris, they looked at cell cycle genes. These are genes that control cells going through division, DNA synthesis, and then dividing from one cell into 2. And there's a whole host of genes that are in that. And then they compare, are these genes being overexpressed compared to some genes that are just normal housekeeping genes that are expressed in all cells, and what are the ratios in there, and how can you use that to then predict what's going on or what might go on. Oncotype DX used a series of cancer-related genes, some of which are related to cell cycle, but others related to invasion and metastases and so forth, and also compared to housekeeping genes. And then the Decipher test looked at 22 different markers, all involved in the cancer process: differentiation, proliferation, motility, cell cycle progression, mitosis, etc. And the way they sorted this out, they might have started with 400 or 500 genes and then looked to see at the end, and I'll show you how they did this, but did they really need all the genes, or could they leave one out, leave two out, leave three out? And they sorted it down into these 22 genes that they could then use for categorizing patients with a genomic classifier. So how are these tests developed and validated? So typically, it's a research group, very often not a company that has been formed yet, and until they get a test up and running, it's sponsored by, for example, NIH funding or American Cancer Society or something like that. Prostate Cancer Foundation, Movember, all have grants that have led to these kinds of tests being developed. Then once you have a test developed with a panel of genes that you can look at, you go to a university and you either look at biopsy specimens that are in the freezer, or, for example, prostatectomy specimens that are embedded in paraffin. And you can then extract the RNA from those and look at how much of that gene is being expressed. And then in the first instance, you know what happened to these 500 patients over time. Some of them did well, never had any recurrence. Others developed metastases. Some even died from prostate cancer. And you look at your panel of genes and the level of those different genes that are expressed and say, okay, we can categorize patients based on just the gene expression and separate patients who developed metastases at 10 years versus those who did not, for example, or people who died at 15 years versus those who didn't. And then you run the gene expression test on all the tissues to come up with that and compare with the clinical outcome. And again, reduce the number of genes needed to predict what happened. You might have started with 400 genes, as I said, but you can then use your database and a computer to figure out maybe you only need 22 genes. And you have your test all figured out, and it's now predicting accurately what happened to that group of 500 patients. But then the next question is, could it accurately predict what happened in somebody where you don't know the outcome? So you go to another university, another collection of samples, and you run your test, and then you ask the university to say, okay, tell me what happened. How good was my ability to predict? And that leads to the validation of these tests. And then you can go forward and potentially make it into a commercial test once you get some FDA approval and that sort of thing. So let's just look at the results of some of these tests. This is the Prolaris test and the type of result you get back. So this was from a patient who had a biopsy done in example, January of 2022. He had a low risk disease. He was favorable intermediate at the time. And so a question in a favorable intermediate patient would be, well, is this person somebody who is, would best be treated by active surveillance, or does he need more aggressive treatment? And this shows the risk of disease-specific mortality if he chooses active surveillance. And you can see this person has a very low risk of disease-specific mortality. Whereas, some patient in a higher risk group, these just show the median of what's available within a risk group when you do this on 1,000 patients or whatever. And this patient could have been way above the median up here in a very high risk group, or he could have been way down here. But in the majority of cases, patients actually show up in the middle of these different risk groups that are clinical risk groups. And very often the genomic test just confirms that and really doesn't add very much information. But in this case, a favorable intermediate patient who might have had a Gleason 3+4 with one biopsy core positive was actually in the lower risk category than you might have imagined. And that's how these tests could be potentially used. Each of the companies reports out their data in a different format. And I'm going to show you all three, but it's been a challenge to use these tests and talk to patients in ways that they can understand and ways that we can understand as physicians. It's like a Rorschach test. Sometimes people see an upside down vase, and other times people see a lion that's coming at them, and it's difficult. And I think it's very important to look at these test results, examples, before you even order a test, because it's, I think, very important to know what you would do if you ended up here versus here versus here. Because if you're not going to make any decisions based on the test, it doesn't make any sense to get the test. If you're pretty comfortable with the clinical characteristics and choosing based on the PSA score and the risk categories that we've already talked about, low PSA, very few cores, 3+3. I don't think you need to have any genomic tests to help you decide to do active surveillance, for example. So this, the Oncotype DX test, they used a sort of different endpoint. They said, well, what's the chances that if we go ahead with a radical prostatectomy, we would find worse cancer than we thought about? And with their genomic test, GPS, it's a classifier system, this particular patient had a 16% chance of low risk cancer. There's a very small risk that he would have a more advanced cancer at the time of prostatectomy. But if he ended up here and he thought he had low risk disease, but he had a high likelihood of worse pathology at the time of radical prostatectomy, it would certainly be somebody that would think twice about active surveillance. And then this is the Decipher, an example of the Decipher results. This is a patient who had a PSA of 3.9, a Gleason of 3+4, so he would be an intermediate risk. But it turned out that his risk classifier based on the genomics was high. And so this is a patient that might benefit from a much more aggressive approach, treatment intensification with multimodal therapy. So, for example, if a patient chose radiation, it's certainly a patient that you would potentially add androgen deprivation hormone therapy to their treatment regimen. So, question then is, ultimately, we've had these tests around for 5 to 10 years. Do they really add anything, and how much data do we have to suggest they should be used? Well, in the case of Prolaris, there are no prospective trials in radically treated patients, but there's a large retrospective study showing some indication that these help. In the Oncotype test, there's one prospective trial in the active surveillance population, and it was borderline significant on multivariate analysis for predicting adverse pathology. So that was kind of borderline. Decipher has had the most prospective multiple randomized clinical trials with prospective registries to indicate, prognosticate about biochemical recurrence, metastasis-free survival, and overall survival. So then the question is, well, could you combine the clinical characteristics, how many cores are positive, what the Gleason score was, even things like what percentage of each core is pattern 4 versus pattern 3, and things like that. And that's a moving target too, because now that we have the MRIs, we get not just a 12-core biopsy, but 2 or 3 more cores from the directed biopsy towards where the MRI is positive. It's creating some challenges because a lot of the published data have to do with just the standard 12-core biopsies. But you can combine the clinical characteristics, how big the tumor was, what the PSA was, PSA density, and so forth, with these genomic classifiers and potentially come up with a better system. So this is from Dan Spratt, who gave this talk this year at the European meetings, and looked at the ability to use the genomic model to reclassify patients. So in the case of sort of looking at the accuracy of tests, if you just use the NCCN guidelines, it's better than flipping a coin. There's another set of tests that's a little broader than the NCCN called CAPRA, and it's slightly better than the NCCN guidelines. But if you combine both the clinical characteristics and the genomic characteristics, you got the highest correlation with what actually happened. And so Spratt reclassified patients. It turned out that 2/3 of the patients that went into this particular study were reclassified. 40% of the favorable intermediate were reclassified to low risk. 41% of the unfavorable intermediate were reclassified to high risk, and 63% of the high risk to very high risk. And then if you looked at what happened to those patients classified in that way since the time of their biopsy in years, you can see that the very low risk, favorable, intermediate, low risk patients really did extremely well, and certainly was a great group of patients that would not have needed any therapy. And then the unfavorable intermediate risk and or favorable intermediate and unfavorable intermediate risk were classified. So they're low, intermediate, and high in this system. Very good statistics, and shows that this genomic classification really does help in predicting what's going to go on. Then the costs for these tests are a little bit hard to determine, but they're not cheap. So another thing to think about then is, do I have to pay for it, or does Medicare pay for it? And if so, how much do they pay? And the companies are all doing what they can to have more doctors order more tests. That's how companies make money. But these tests are between $3,000 and $5,000, and they're covered by Medicare in certain situations, but they're not covered in others. And so very often the marketing people will come to us and say, well, you can order the test. We'll guarantee you that the most that a patient will pay out of pocket is $500 or something like that. Well, that's attractive, but it's not necessary. It's more marketing than it is, are you going to really use the results? And so these patient assistance programs are in place because the companies, even though they charge this much, probably doesn't cost them near that much to run a test. You can do a whole genome on a human now with all the DNA for about $300 or $400. So if you're just looking at a series of 20 genes, it's way less than that. The tests are covered by Medicare, as I said, in some situations, and definitely in clinical trials. But you get into some tough questions here. I found this when I was putting the talk together from a couple of years ago, that the company Genome Biosciences had to pay a $2 million fine because Decipher tests that were not medically reasonable and necessary, the patients didn't have risk factors necessitating the test, and then they named it pathologic T2 disease, meaning palpable with a positive surgical margin, stage T3 disease, or a rising PSA after initial PSA. They didn't fit the Medicare criteria. These criteria change. It's a moving target, but it's something to consider. And the doctors and the insurance providers and the Medicare situation all have different motivations, and patients have different motivations too. But as patients, I think we all need to be cognizant of the fact that just because a test's available, it's not necessary to order it, and what would we do with it if we got a result back anyway? So here are some examples, I think, of where a genomic test might influence a choice for active surveillance. So let's say you have a young patient with just a few more cores than we normally think of as being the ideal for active surveillance. Got a Gleason 3+3. He's a grade group 1 patient, but 4 out of 12 cores is a little bit scary, and less than 55. He's got a long time to go. And maybe if we had a lot more confidence that he was in a low risk group, we'd just say, absolutely, we're going to keep a close eye on you with whatever active surveillance protocol, and we encourage you for sure not to go through with therapy. What about a 65-year-old man with a single core of Gleason 3+4, small central lesion on MRI? So he's a low intermediate risk patient. Pretty good candidate for active surveillance. Again, a low score on a genomic test would confirm the good feeling about that. And here's a 70-year-old guy with a large number of cores. They're all Gleason 3+3, but his father also developed prostate cancer, so there's something going on in the family maybe, although his father died of other causes. So there are things going in different directions in this gentleman. And again, a high risk versus a low risk genomic classifier might really help. And then lastly, we see patients who have abnormal things that don't come out in the Gleason scoring system, like ductal cancer, or patients with a family cancer syndrome that we know can lead to increased risk in prostate cancer, like BRCA mutations. So those are patients, again, where genomic classifiers may be helpful. We don't really have the answers on that yet. The expert recommendations are are pretty conservative. This is the NCCN guidelines, where active surveillance is preferred with for most patients with low risk prostate cancer and a long life expectancy. But they recognize there's heterogeneity and a high number of positive cores or a high genomic risk from one of these molecular studies, or as I said, a known BRCA2 mutation. In some of those cases, upfront treatment might be preferred, and again, shared decision making with the patient. The AUA guidelines say that clinicians can use tissue-based genomic markers when added risk stratification might change your opinion about what to recommend, but they should not use tissue-based genomic biomarkers routinely for decision making. So that's conservative, and they think that the better course of action is to continue to use what we currently use and not just reflex order expensive genomic tests on every patient. Again, what would you do with a test result? The majority of cases, actually, when you order such tests, the tests come out in the middle. An intermediate patient comes out with intermediate risk for metastases, and they're not at one end of the scale or another. And again, there are no prospective validated studies that show that if we make a decision based on using such a test, that it's actually results in better outcomes. So both the physician and patient should look at the genomic reports that I've shown you before even ordering them and consider whether a certain result would influence their decision making regarding treatment. Now, this is in contrast, I think, to later disease, where we have, in this case, we're looking at the Decipher results, and we are already using these tests to decide how aggressive to be in therapy. So a patient with very high-risk disease might benefit from adding hormone therapy to radiation, for example. And that's becoming a pretty routine type of recommendation. And this guy might have had up here he has a Gleason 4+3. He could have ended up with 4+3 and low risk, and maybe we wouldn't have added hormones, or maybe we would add hormones for a shorter period of time if the patient was in the low risk category, even though they had Gleason 4+3 disease. So that's an example of how the more advanced disease we can use these. And fortunately for all of us, there are some great clinical trials going on to de-escalate the intensity of therapy in patients with low risks on the Decipher score versus intermediate or high risk. And if you're a low risk Decipher score in this clinical trial, for example, you're then stratified into radiation therapy alone versus short-term hormone therapy plus radiation therapy. And if you ended up in the intermediate or high risk disease, everybody gets some short-term hormone therapy, but some people get an additional drug, darolutamide in this case, that intensifies the hormone therapy. In summary, genomic markers help us to define risk categories in prostate cancer. For example, they might help separate patients with intermediate risk, say Gleason 3+4, into low or high categories that are different from and reflect other genetic changes not just seen in the Gleason classification. Second, they are unlikely to change risk management for patients with low volume Gleason 3+3 disease. Most of the patients watching this video are probably in that category. Third, tumor markers come from biopsies and prostatectomy specimens. That is, tissue is sent from the biopsy or the prostatectomy specimen to a laboratory where the genetic tests are performed. That's in contrast to number 4, inherited markers can be evaluated with blood tests or saliva. These are the markers that one inherits from their family and may or may not be playing a role in the actual tumor itself. Families with many different kinds of cancer or a primary prostate cancer in a relative like a father or a brother should seek the help of genetic counselors with regards to looking for genomic markers. And finally, most expert societies would not recommend genomic markers for Gleason 3+3 patients who have no positive family history. I hope this has been helpful, and thank you very much for your attention.
Thank you, presenters. Excellent. I want to remind everybody that we will take your questions on the chat room, and there have been several questions already presented. I'd like to ask both presenters to reflect on the following question that came in. Is there such a thing as redoing your genetic and your genomic test later in life, or later during your, journey with prostate cancer?
I can, make a quick comment. What you inherit from your family is not going to change. So once you've had 23andMe, that's who you are. And interestingly enough, as I mentioned in the presentation, there's, these days it's $400 to get your whole genome done. So that's changing very quickly. And, Rob may want to talk about that. I suspect in the next decade, maybe it'll end up being that all babies have their whole genome done. and then people will use artificial intelligence to say whether they should go to college or not. Who knows? But the contrast is tumors. So somebody asked a question about circulating tumor DNA. That changes. So if you do a tumor genetic analysis early in somebody's disease, the mutations that continue to occur as the patient's disease progresses with different kinds of clones of cells becoming dominant and so forth can be picked up with repeating those tests. The question then becomes, how much information do you get that's really valuable? We know that the tumors, as they progress, develop more and more genetic mutations. Sometimes those genetic mutations are dominant and could lead to a different kind of therapy. The best example right now is PARP inhibitors, which are, I won't go into it, but basically it's a category of mutation that allows you to use a certain class of drugs for treating patients with that. And you might not see that early in somebody's course with metastatic prostate cancer, but later it becomes dominant and they could benefit from that particular class of drugs. So I'll stop there and let Rob comment.
Sure. So, when we're talking about the hereditary cancers, like he said, we're born with the genes that we're going to have our entire life. So you only need to have that test done once. The only thing that I would caution is that there are medical grade genetic tests that you would get from, Myriad Genetics or Ambry or Invitae, et cetera, some of the more commercial medical grade tests. Then there are non-medical grade tests like the 23andMe that don't really look for the same genes. In fact, in the genetics world, we kind of call them commercial, or we kind of call them recreational tests, because they can tell you, whether you have wet earwax or not, or whether you're prone to depression, et cetera. But they don't really give you the medical grade tests that you can get from laboratories that are less direct to consumer and more ordered by physicians.
Thank you.
And I just add to that, it's pretty interesting that the world keeps moving. So in the cancer world, as Rob knows, there's now much larger panels. I mean, my genetics counselor, when I see patients that are appropriate with a family history and so forth, and order the kinds of tests that Rob just mentioned, sends off a panel that's maybe 80 genes or something like that. UCSF now has a 500 gene panel. And a lot of the other, major cancer centers, MD Anderson and Sloan Kettering have their own, groups. And those are medical quality tests, but they haven't been commercialized yet. So it's a rapidly evolving field.
Thank you. Thank you both for that. Martin, did you want to provide any questions? Martin is helping me this morning with fielding the questions. Otherwise, our presenters, if they happen to see any, can jump right in. Martin, is there anything from you?
Sure, just a quick one. There seems to be a general concern about the availability of genetic testing for veterans, the VA, obviously. Can either of you address that issue?
Rob?
So genetic testing is covered by Medicare, but we do have some, individuals who go to the VA hospitals who don't get it, and that's because, and correct me if I'm wrong, Dr. Glode, but the VA gets a certain number of dollars from the government, and then they decide what to use those dollars for. And so sometimes the priorities are a little bit different than going to a private doctor or a hospital system other than the VA.
Thank you. I have another question from one of our audience. Does a unique family background, we call unique genetics, affect genetic and perhaps genomic testing? Let's say we have Northern Europeans, which let's say we have Southern Africans. So let's say we have Eastern in part of China. Do any of these predilections from a person's family background, perhaps stronger in some parts of the world than others in terms of predetermined marriages, if you will, closer clans? Does this have an impact on genetic and genomic results?
Yeah, that was a lot of questions wrapped into one, but let me just sort of say that, for the most part, across the world, we all have the same genetics. Certainly we know more about the genetics of Northern European Caucasian individuals just because that's the population that has been tested the most. So when we start seeing genetic testing done in other populations, we are more likely to find what we call variants of uncertain significance. So changes within the gene that we just haven't tested enough of that population in order to be able to determine, what that change means. But as far as the genes themselves, we all have the same genes across the world.
But Rob, you might mention, for example, the Ashkenazi Jewish
sure, yeah.
population with BRCA2.
Correct, yeah. So in the Ashkenazi Jewish population, we do see about 1 in 40 individuals who have a BRCA1 or BRCA2 mutation. And to compare that to the rest of the population, it's about 1 in 400. And so that population is more likely to have a BRCA1 or BRCA2 mutation.
Okay. Martin, did you have another question for us?
Yeah, there's another question from the chat. And I'm not sure that you addressed this. Can we not test tumor markers with circulating DNA, not just tumor tissue?
Yeah, so circulating DNA is very exciting, and it's used more in some other cancers. We're not quite to the point of using it in prostate cancer. Let me just sort of back up and talk about what circulating DNA is. So circulating DNA is cells that have sloughed off from the tumor itself into the bloodstream, and then you can just take a blood sample and be able to find those cancer cells in the bloodstream, or the DNA in the bloodstream. Well, prostate cancer doesn't shed as much as some of the others. And so it is something that we're actively looking into, but it's not, I wouldn't say that it's mainstream yet in prostate cancer as much as it is in some of the other cancers.
Yeah, let me just add to that. There's a nice article in the Lancet last week, or last month, I guess, by William O. and one other author, I can't remember, but ctDNA is extremely sensitive. And it's very exciting if you're a colon cancer oncologist, because finally, in those in some diseases where there haven't been markers like PSA, there's this now high sensitivity technique to see if the tumor is really gone or not. PSA is so sensitive and has been used so long. We have all of this information about, what's the positive chances of a positive PSMA scan if your PSA is 0.2 versus 0.4 and stuff. All of that, we're not going to get anywhere. It's, in my opinion, very unlikely we'll get anywhere with ctDNA from the standpoint of sensitivity. And the other cancer areas are going to face all the same issues that we have faced, we in the prostate cancer community, for a long time. You know that somebody's PSA is creeping up 5 years after their initial prostatectomy, we'll say, and we've all been dealing with that. What do you do? What kinds of scans make sense? And What are you going to do if you find any cancer and that sort of thing? So everybody, I mean, the pancreas cancer people and the colon cancer people and all that are now going to have to deal with that. The second piece that's going to affect Rob's world is the pan cancer test. So there are a couple of companies now that are looking at, a bunch of different genes that are that sensitive, and you can go in if you're a normal person and have them draw blood and say, do I have a ctDNA marker that says I have cancer? Well, there's going to be false positives, false negatives. And if you had, oh my God, there's a signal right there, and you do a bunch of scans and you don't find anything, now what do you do except you don't sleep at night? So there are a lot of challenges with that. It's an exciting time, but it's also going to create a lot of, and then who pays for it? How many scans, negative scans do you do before you find a cancer? And if you've done 1,000 negative scans to find one cancer, is that cost effective, or would that person die of a heart attack anyway? Huge numbers of questions that have to be answered as we, deploy this kind of technology. It's really, I won't live to see the end of it, but it's an exciting time in medicine, that's for sure.
Well, we want both of you around for a very long time. I have another excellent question. What does reflex order mean?
So reflex ordering, some physicians will say, okay, every Gleason 3+3 cancer, I want to automatically have the pathologist order Prolaris or a Decipher or a Oncotype DX. And so it's just done reflexively. Whereas, some physicians are like, I want to hand pick which of my patients will get this test. And so that's just the layman's term for, automatic ordering.
Dr. Glode, any further on that?
No, I think that's fine.
Okay. Martin, would you like to present a question?
Yeah, there's a question, it's a general question about the reluctance of Europe in Europe and Canada for genetic testing. It's a pretty general topic, but it's been coming up in the chat. Rob, would you want to address that?
Sure. I mean, I think it's similar to what I said about the VA. The health systems in other countries, choose how they want to spend their money. And some of them don't choose to spend their money on genetics and genomics. And so, I was just speaking with a urologist the other day who'd practiced in the UK and had no idea about the genetics and genomics of prostate cancer because that just wasn't something that came up in the UK. And so, again, it's more about the national healthcare system than anything else.
Thank you.
Thank you. Let's see.
Yeah, I'll just add a political comment to that. It's all well and good to say, we should have every test available that makes sense. And when you're practicing medicine, people say, why can't I have a scan every month? I think if you had a finger stick PSA test, there are patients who would wake up every morning and finger stick themselves. And ultimately, the US right now is spending like 19% of its GDP on healthcare, on a medicine. And I think especially with the genomic and genetic revolution, we physicians, the medical system can bankrupt this country. I mean, it's unbelievable the amount of technology that we now can deploy. And I don't know where that goes. It's a societal issue that I can't solve. The cost of drugs has been, front and center in the last, month or two. And trying to control our healthcare costs is a real challenge for our country. And some of these countries that are, that have a limit, they say, okay, we can spend 15% of our GDP. Let's have society decide on it. In the UK, they have NICE, it's called. And they decide, how can we deploy 15% of our GDP or whatever the number is most effectively to save most lives and give the highest quality of healthcare to the most people. And right now we're not doing that. We're in the Wild West where everybody who wants a test can order it, and we all bitch and moan when we don't get it paid for. So it's a real challenge.
And, I might add to that, Doctor, counterpoint, if you will, very politely, of course, is we have the whole question of equality in the United States. People of color, people of lower socioeconomic means, they probably have never heard of these tests. For example, a homeless person living under a bridge, perhaps even a younger man there. Again, we know, of course, more than I do, given your background and your research, but I often stop to think of people who don't have the equality in medicine. And this is, something that kind of rings around our neck.
Absolutely. It's a great point.
Thank you, sir. Martin, another question?
Let's see. Actually, Jeff, what do you think about the idea of if there's anybody that has a burning question that hasn't been answered, to use the raise hand feature at the bottom of their screen?
Yeah. Okay, why don't we open that up? Thank you, Martin. Excellent. And of course, either of our presenters want to focus on something that we passed over, certainly, gentlemen, speak up. Let's see here. Anybody in the audience, we can be muted.
Raj, would you like to ask your question?
Yes, my name is Dr. Warrior. My question is there any study ongoing where they're doing whole genome sequencing, all tumors, to find out specific markers? Rather than in pediatrics, we find a lot of new markers that are never thought of. Is there any national study?
Not that I know of. Whole genome sequencing is really helpful in pediatric genetics, like you said, but for cancer, I think that, most of us are using next gen sequencing of a preset number of genes. We're not quite into the whole genome sequencing yet.
I have one more question. Is there any known predisposition syndromes that leads to prostate cancer, like leishmania, anything that's well known to predispose to prostate cancer?
Yeah, so the most common is, unfortunately, it's named hereditary breast and ovarian cancer, which is BRCA1 and BRCA2. And it's a misnomer because, it's more than just breast and ovarian cancer, but that's the biggest one. And then mutations in CHEK2, ATM, HOXB13, those are the most common genes that increase the risk for prostate cancer.
Okay. And I just had a comment as a pediatrician, because we are seeing a lot of transgender surgeries being done now. And I just want to remind the adult doctors that when males become females, they still get prostate cancer and people don't screen for them. So that's a new thing that's coming up in pediatric oncology training. So just to remind the adult oncology groups about the transgenders who became males, become females, become males become females, they still have the prostate, people miss that cancer. So just some hint, that's also.
And I would add too that, hormone therapy for transgender is something that you want to think about, especially because a lot of these cancers are hormone driven. And so that's becoming an issue as well.
Thank you very much. Very nice talk. Thank you.
Thank you, Raj. Thank you, Rob. Ken, would you like to ask your question? Ken Cohn?
Can you hear me?
Ah, there you are.
Okay, thank you. There's a strong history of prostate cancer in my family, and I've also got 4 sons in their 30s and 40s, and I've urged them to have their PSA tested, and they've replied that they've talked to their doctors and have been told that they're too young to start that. And from what I've heard, they're not too young. But what are your thoughts?
Well, the NCCN guidelines recommends most individuals start screening at the age of 45, and that those with a germline mutation or African American ancestry start at 40. So yeah, in the 30s, maybe a little bit too young, but guidelines say by 40.
There's
40 or 45?
Yeah, 45,
40.
but there's another issue that 40 for if you have a positive family history is the current recommendations, yeah, or if you're African American. But there's another intriguing thing that you should know about for your family, and that is the PSA. We've already talked about how sensitive it is. A lot of family practice docs and so forth just look at the normal range instead of an age-related range, and that's been studied extensively. and this is my recommendation, and it's not guidelines, but if your kid is 40 and has a PSA over 1, that's still normal, but it's not normal. So, and there's plenty of data on this. I could back up what I'm saying. So if you, it's intriguing that if you have a let's say you're 50 and you have a PSA of 1.5 or less, your chances of having a higher PSA at age 55 are vanishingly small. So you could use less than 1.5 at age 50 to say, I'm not going to get screened again until I'm 55 or 60, whatever it is, numbers like that. At age 40, it should be less than 1. So when I'm talking to medical students or whatever, so I say less than 1 at 40, less than 2 at 50, less than 3 at 60. If you're not on those numbers, on that, guideline sort of broad brushstrokes, you got to be a little more careful, and especially with a positive family history. Mm-hmm. So if you have prostate cancer and one of your kids has a 1.1 at age 40, I would check it again at age 42, that sort of thing, and be more aggressive about surveillance and watching more closely. It's an age-related number.
Yeah, one more thing to add, especially since we're talking about age, the general consensus is that, follow the NCCN guideline. But if you have really young cancers, you want to start 10 years before the earliest cancer in a family. And so if you have somebody who had prostate cancer in their 40s or 50s, you definitely want to go 10 years younger.
Wow, it's a surprising. Howard Walensky. Howard.
Hey, excuse me, I think I'm on. I was at a support meeting the other day where a gentleman was 81 years old and was considering his options. And so the question came up about his genetics. And it turns out that his father died from prostate cancer in his 80s. But I don't believe he was diagnosed till probably his 60s. And so I wonder about age in all of this. If somebody is in their 80s and their dad died in his 80s, is that really a genetic factor? I always thought that it was more a matter of some guys in their 50s getting diagnosed young, like their fathers were. So where does age fit in?
Yeah, so we do expect that if there's a germline mutation, we tend to see cancers earlier. That's more dramatic, I would say, in, like, for instance, breast cancer. So when I was going through that family history, I said, if you have a grandmother who had breast cancer at 95, that's less concerning than someone who had breast cancer at 45. So typically we do see younger ages of onset. With prostate cancer, it's not as dramatic though. And so age is becoming less of a criteria for prostate cancer than, for instance, having metastatic prostate cancer.
A couple other comments. One is that lethal prostate cancer tends to run in families for genetic reasons that we don't fully understand. But if there's a family where the brother and father both died of prostate cancer as opposed to got prostate cancer, that's something to pay a little bit of attention to, even though, and we may not know what the genetic background is that leads to that. But it's a true phenomenon. The second issue is the guidelines are pretty specific about age. They say the AUA guidelines have typically said when you have less than a 10-year life expectancy. Well, that gets harder and harder to predict. But if your 80-year-old friend at that support group, has had a heart attack and is currently using oxygen at night, I'd say there's no reason to spend a lot of time screening. As probably everybody on this call knows, if you autopsy 90-year-old men and go through the prostate very carefully, about 80% will have an early cancer. Those are the ones we don't want to pick up. I mean, who needs to know if you've got a low-grade cancer, but you're going to die at age 92 from a heart attack anyway? It's better not to know about it, so that the darn urologists, and I hope there are no urologists on here, don't come after your prostate. And I will, since I mentioned the urologists, somebody asked the question about which test is best. I think you have to talk to somebody who's used to using the test. I'm not a urologist, and some urologists favor one test over another. And once they have experience and can use that for their counseling, that's what to go with. I don't think there's necessarily any reason to pick one test over the other. I did mention that Decipher has more prospective data than the other tests, but that's kind of where things are right now.
Thank you. Thank you. Steve, you want to give it a shot?
Yeah, just one question here. Dr. Glode and Rob, wonderful presentation. Would like to see this done again. As reported prior to the pandemic at PCRI in LA, one researcher was saying, establish a baseline of a young person. And I don't remember the age that he was suggesting, but that it was important to actually go back to childhood and start this PSA monitoring. Is there an advantage? Have you seen the research that says that there is reason to start a young person and continue throughout their life taking a PSA? Thank you.
I'm not aware of any data to support that kind of recommendation at all. I would have to defer to somebody who could prove it to me. I seriously doubt that makes sense, but I already made, a non-expert recommendation about age 40, 50, and 60. And I can stand by that with some data, but I don't, starting a PSA test when somebody's 20 makes no sense to me.
We're closing probably at 10:30, so I'd like to ask Raj, and if there's anybody else, put your hand up right away. Otherwise, we may close with Raj. Please address the question, sir.
I just want to add to the oncologist's comments about screening for cancers very early. Unless it's a known predisposition syndrome, we never screen them routinely, but most hereditary cancers occur before the age of, certainly before 40, but even before that. So if you're a hereditary gene defect, cancers occur much earlier, not so much later in life. So if it's beyond 40 or 50, it's much less significant. So
in most cancers, yes, I think prostate cancer is a little bit different. We still see the majority of men with mutations are still over the age of 50 by the time they're diagnosed.
But how do you know the mutation is not the cancer itself? And it may not be the cancer causing mutation, maybe mutation due to the cancer itself. You know what I mean? Are they hereditary?
I actually don't understand the question. I'm sorry. I got a personal message in here and I got distracted. Can you repeat the question?
No, my comment was that if you have cancer later on in life, are you sure it's hereditary, not an acquired mutation?
So certainly there are, what we call sporadic cancers that just happen by chance or aging or whatever within hereditary cancer families. So certainly, if somebody has a BRCA2 mutation, they develop prostate cancer, there's no guarantee that the BRCA2 mutation caused the prostate cancer. But I think most of us, there's really no way to know for sure, but most of us would probably attribute it to that germline mutation.
Okay. Thank you.
All righty. Well, there being no further questions that we are aware of, I want to thank everybody for attending. I want to invite everybody to attend our future programs, which are well noticed on the internet. I want to thank our team here today, board who put together. And at this time, I want to thank particularly Rob Finch and Dr. Michael Glode. Dr. Glode, I'm sorry you missed your tea time this morning, but I know that we're going to all live longer for it.
Thanks. Well, I delayed it. I'm about to head out, so that's we'll see if we can break 100. It's unusual.
All right, and I want to certainly thank Myriad Genetics and their team for providing us the resources, the time, and the knowledge for this morning. As well as the doctor, and then some of you here who have addressed some excellent questions. Come back, come see us. And finally, if you have a few spare bucks around, go to our website and hit the donate button because the more the merrier. And then finally, embrace your family because genetics is what it's all about. Thank you very much.